So we'll start with our land acknowledgement. And I'd like to start by acknowledging that we at St. Joseph Healthcare Hamilton sit on the traditional territories of the Mississaugas and the Haudenosaunee Nations, and this is within the lands protected by the Dish with One Spoon Wampum Agreement. This is a treaty between the Anishinaabe, Mississaugas, and Haudenosaunee that bound them to share the territory and to protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. And with that, I'm delighted to welcome our speaker today. We have Dr. Mino Mitri, who's going to be bringing us a new perspective on crucial conversations with patients and their families. I'm really excited about this topic today, and also grateful to my colleague, Dr. Jason Chung, who is our GIM, General Internal Medicine Head of Service here at St. Joe's, co-hosting our rounds today with me, and I'm going to hand things over to Jason to provide Dr. Mitri's introduction.
Thanks so much, Madeline. Brings me great pleasure to introduce you all to Dr. Mino Mitri. Many of you may already know him as one of our GIM division members. He joined us about 2 years ago here at McMaster as an assistant professor in the Division of General Internal Medicine. And prior to that, he completed his medical training at McGill, Queen's University, and UBC. In addition to joining our Division of General Internal Medicine, he is also a member of the Division of Palliative Care Medicine within the Department of Medicine, and he's the inaugural PD for the Royal College training program in adult palliative medicine here at MAC. His clinical and academic interests include palliative care and non-malignant diseases, sexual medicine, palliative medicine education, and of course, as you'll tell from today, improving the art of medical presentations. Mino, I'll hand it off to you.
Thank you so much, Dr. Chong and Dr. Verhosik for the introductions. I'm excited to be here this morning. Just to give you a heads up, so this presentation is divided into 2 parts. There'll be a 1-minute cyber break in the middle of the presentation to give you an opportunity to reply to that text message or send off a quick email. And there'll be ample time at the end to answer any questions you may have. Until then, I invite you to sit back, relax, and enjoy the presentation. I will give you a heads up. The lights here are automated and may turn off at some point, so I may stand up and turn the lights back on. And we're in my office, so I know I am wearing pants for this Zoom presentation. Imagine this. You're reviewing a case of a patient you have been following in your outpatient practice or on the inpatient wards. A change in the course of your patient illness has prompted you to question the use of an intervention. Do I insert a feeding tube in my patient with advanced neurological disease? Do I refer my patient for a biopsy to investigate the likely underlying malignancy? Do I consider a transfer to a critical care bed for invasive ventilation should their respiratory status worsen? Do I start dialysis? Do I send them for a pacemaker defibrillator? Do I perform a paracentesis? Do I start an immunosuppressive agent? No matter the question, you're about to enter your patient's room to talk with them and their family about the intervention, hoping they will make a sensible decision. But is that a fair expectation? Patients and families look up to us to assist them in navigating this complex world of healthcare, particularly when it comes to serious illness and life and death decisions. They need our expert recommendations to provide them with guidance, relief, and validation. In a study published in the Journal of Palliative Medicine and conducted at the University of Toronto, the authors gathered clinicians with expertise and experience in end-of-life care and communication. There was consensus amongst the palliative care and critical care physicians in the study that patients and their families should receive a recommendation when discussing life-sustaining therapies because they offer them guidance while helping to shoulder some of the burden of decision-making. So to engage in crucial conversations with patients and their families, you must be prepared to make an expert recommendation. I have no conflict of interest to disclose, but I have an interest to increase your confidence in making an expert recommendation to patients and their families when engaging in crucial conversations. But first, what are crucial conversations? There are obviously many examples of this, like conversations about CPR, intubation, artificial hydration and nutrition, lung transplantation. But there may be some less obvious ones, like conversations about starting opioids for dyspnea, choosing an inhaler, or even getting a walker. What makes these conversations particularly crucial? When we look at the definition of crucial, it involves an extremely important decision or result. So to determine whether a conversation is crucial or not depends on the magnitude or the impact of the decision to be made on the patient. So a conversation about CPR could actually be quite easy for a patient, pretty straightforward. We've all had these conversations with patients who said, I have a DNR already signed, no CPR, thank you very much, just look at my paperwork. This is not a crucial conversation. But with the same patient, a conversation about opioids for dyspnea suddenly becomes very crucial because of the perceived dangers of opioids, the misconception that they're actively dying should they start opioids, or a fear of the side effects. It has now become a crucial conversation. Now, as I said, to engage in crucial conversations with patients and their families, you must be prepared to make an expert recommendation. But how do you make an expert recommendation? Particularly when faced with many granular questions. Do we continue antibiotics? Do we intubate? Do we stop IV fluids? Should we try non-invasive positive pressure ventilation? And many, many more questions. I want you to take a moment to reflect on a particularly challenging case you may have encountered, where you may have engaged in a crucial conversation with a patient and or their family members. What was particularly challenging about that case? What made the conversation crucial? What was at stake? I would invite you to keep that case in mind as we navigate the steps in making a recommendation. Now, the key step in helping you make an expert recommendation for your patients is to determine the goals of care. But let's be clear here. Goals of care is not a code status. This may be obvious for many of you. However, I can't tell you the number of times I've asked colleagues, what is the patient's goals of care? And they tell me full code, or palliative, or full active medical management. That is not a goals of care. That is simply a code status. And a code status is only for emergency care. It only tells us the maximal amount of interventions that can be performed in the event of an emergency. So what are goals of care? The key word here is goals, objectives, targets, purpose. Where are we going? What are we trying to achieve? So when I think about goals of care, I tend to think about it in three large categories: prolongation of survival, optimization or preservation of function, and finally, optimization of comfort. Let's look into this a little further, starting with prolongation of survival. This is the living as long as possible, the obvious focus on quantity of life. However, patients may describe living up to a certain event in time, such as an upcoming wedding, birth, or simply the arrival of a loved one from a faraway city. So there could be what I call conditional survival. The second category is the optimization or preservation of function. Now, this is the all-encompassing function. We often think about function as the physical function, moving, walking, transferring, etc. But there's also the psychological function, the social function. Patients may describe wanting to preserve functional autonomy, like going to the bathroom on their own, being able to make decisions for themselves, or spending time with their loved ones. The third and final category is optimization of comfort. Now, this is what I like to call the cozy goal. Comfort is this warm blanket wrapped around you on a cold day, a hot cup of mocha with just the right amount of sweetness, soothing music to calm the soul, the loving embrace of your partner, holding you close to their warm, soft skin. This is comfort. It doesn't always require medications, but oftentimes requires attention to the small details. Charged cell phones, tray tables at reach, the ability to call out for help. These are all comfort interventions. So survival, function, and comfort. These form the goals of care. Now, this is not a choose one option only. If I were to ask any of you, if you were sick in hospital, what would you want as your goals of care? Who wouldn't want to survive as best as possible, live as long as possible, function as best as possible at the outset of it all, and be as comfortable as possible throughout the whole process? But what I often keep in mind when speaking with patients and families is that if we focus on survival, it may come at the cost of comfort and function. For example, patients with prolonged stays in the ICU may see their comfort compromised during admission, and if survived, may have a loss of function. We must ask patients whether these risks are acceptable. For some, it is, and for others, it's not. But the opposite is also true, wherein if we focus on comfort, it too can come at the cost of survival or function. Many medications we use for symptom control can have adverse effects such as increased sedation, which impedes on their ability to function, or can have some cardiac side effects, which can potentially impede their survival. Again, we have to wonder whether these risks are acceptable. For some it is, and for others, it's not. Focusing on function may in turn also compromise survival and comfort. I recall seeing a patient not too long ago who declined further antibiotic treatments for non-tuberculosis mycobacterium because the side effects of the antibiotic compromised her ability to function on a daily basis. But that may come at the cost of her long-term survival. Other patients who are severely weakened from a progressive life-threatening disease who want to continue to function but find the simple acts of getting out of bed, eating and showering causing so much discomfort. Again, you wonder whether these risks are acceptable. For some it is, and for others it's not. And this is not a linear relationship. Some may choose survival and comfort as their primary goals of care. Example are people with non-progressive, oh, there we go, light turned off, get it back on. Okay. So not a linear relationship. Some may choose survival and comfort as their primary goals of care. Example are people with non-progressive neurological conditions as a result of a stroke or any other neurological disease. Function can't really be optimized any further, but they wish to live as long as possible while being as comfortable as possible. However, many patients do not aspire to such goals. Why? Because their quality of life is potentially compromised. Function is arguably the most important factor determining quality of life and hence often the most important goals of care, yet the one we talk about the least. It begs the question, what is quality of life? We know that it is a subjective answer, but it often boils down to functional status. In several studies, a strong association between functional status and health-related quality of life has been established for many disease states. In fact, loss of function was among the strongest predictors of desire for hastened death and pursuit of euthanasia in several studies. We erroneously think that quality of life equals comfort, but in fact, when reviewing literature in palliative medicine, it's more related to a sense of being a normal human being, having the ability to function normally. I often use exercise to illustrate this further. We know that exercise is important and beneficial for your quality of life. How comfortable is it to exercise? It's not comfortable at all. And if you find it comfortable, you're probably doing it wrong. And the same applies to many of the palliative medicine interventions. They're not very comfortable. Surgical interventions, radiation therapy, immunotherapy potentially, drains that are inserted to relieve obstructions. These are all palliative medicine interventions in the effort to improve quality of life, the ability for the patient to function better. The process may not be comfortable, but ultimately their quality of life is improved. Comfort may actually improve quality of life. Focusing on comfort, the symptoms that we're addressing oftentimes impede on the ability to function. So it's not just I'm sitting in bed and I'm having pain and hence I'm bothered. It's I'm sitting in bed and I'm having pain and I can't fill in the blank. Eat, talk, focus, sleep well. And therefore addressing the symptoms will also help to improve function and thus improve quality of life. So when patients or families mention quality of life as their primary goals of care, they are usually referring to optimization or preservation of function, but I'll probe to better understand what exactly they mean. So goals of care often fall into one or more of these categories, that is, optimization or preservation of survival, function, or comfort. So how do we determine where the patient falls amongst these three categories? What do you need as information to formulate the goals of care? When formulating goals of care, there are three elements to take into consideration: the patient's experience of the illness in and of itself, and the patient as a person. Let's dissect this further. The first is the patient's experience of the illness, which is the way they experience the illness, which may affect priorities for their life. We know that an illness may have a lot of impact on a patient in many different facets. For example, there is the physical impact of the illness. Patient with COPD who may have shortness of breath and cough. There may be side effects from medications. They may be experiencing other related symptoms as well, such as nausea. There is the practical impact, the day-to-day management of the illness, remembering to take medications, checking their glucose levels for diabetics, getting their inhaler technique up properly, managing the oxygen tank or compressor. For many patients, it may be easy. For patients with diabetes, they have a routine already established. For other patients, this is very difficult and challenging. There's obviously the psychological impact as well. How is it living with dementia? How is it living with heart failure? It may cause anxiety, confusion, distress. There's the spiritual impact. This is their views on the purpose and meaning of life, which may be altered. Some patients will say, why is this happening to me? Why is God punishing me? So the illness may have an impact on their spirituality. It may also have a social impact, their ability to maintain relationships and socialize. We know that patients with advanced disease tend to isolate themselves. And finally, there also may be a functional impact. How is it living with end-stage liver disease? Many of them complain that it's hard to move around. They feel like they're carrying so much extra weight with the amount of ascites. And functional impact also is a surrogate marker for the stages of an illness, which is the second category to take into consideration. The more we know about the illness, the better we can formulate realistic goals of care based on viable options. This is our responsibility to know as much as we can about the illness. Now, oftentimes when I see patients in hospital, I start by mentally stepping back, looking at the bigger picture and reorienting myself. Now, why do I do that? Too often in the acute, we focus on the disease tree, call it pneumonia. But one must take a step back and realize maybe the entire forest is diseased. What is the context of this pneumonia? Is it a pneumonia in an otherwise healthy, young person with no other morbidities or chronic conditions? Or is this a pneumonia in a patient with advanced dementia and from a nursing home with decreased level of function? Or is it a pneumonia of someone with advanced metastatic disease with no further oncological treatment options? The entire forest is important to take into consideration because it may impact the goals of care. So when we think about the illness, we have to think about, have we exhausted all disease-modifying therapies? And not only for the acute illness, but also for the underlying chronic progressive illness. I may need to consult colleagues or other experts in the field to be fully informed whether all disease-modifying therapies have been exhausted. We must also think about interventional procedures. For many of our patients with non-malignant diseases, I ask, have we considered transplantation? Are they a candidate? Whether or not they are a candidate may significantly alter the goals of care. What is their functional status? I mentioned this earlier. This is really important. And I particularly look at the rate of change in their functional status. What were you able to do, say, a month ago, 2 weeks ago, that you're no longer able to do now? And what has been the general trend in the last few months or year? Because this gives me an idea of the prognostication of the disease. Now, when we think about prognosis, too often we think about prognosis from a mortality perspective. But again, a lot of patients and families are more curious about prognosis from a morbidity perspective. If I were to survive this acute illness, what am I surviving to? How am I going to be at the outset of this disease, of this pneumonia? Because are they surviving to a condition that still has other disease-modifying therapies and interventions that may improve their quality of life? Or are they surviving to a progressive disease where there are no more interventions and they are on this pathway to ongoing functional decline? Knowing the prognosis of the acute illness, the chronic illness, from a mortality perspective, from a morbidity perspective, are all key. And this may shape the patient's decisions as they consider who they are, which is the final category, the patient as a person. Who they are as an individual may alter healthcare options and decisions. When I think about the patient as a person, I ask myself, who is this person? What is their makeup? What is their personality? You may have two phenotypically similar people, both in their 70s, retired with advanced heart failure, but differences in values, needs, personality, sexuality, spirituality, financial situation, relationships in their lives, etc., will affect decision-making. So all three are needed: the patient's experience of the illness in and of itself, and the patient as a person, to begin to formulate the goals of care. That is survival, function, and comfort. So how do we engage and make a recommendation? I will let you know after this 1 minute cyber break. This is where I'm going to drink some water. And if anybody wants to send me an encouraging text, I very much appreciate that. But please go ahead, send that text message or email. We'll check. Thank you for the encouraging text messages. Thank you for that. Okay. So, what is the other key step in formulating goals of care and making a clinical recommendation? As I've said, to engage in crucial conversations with patients and their families, you must be prepared to make an expert recommendation. What we haven't explored yet is the word engagement. But how to engage? Now, this could obviously be formal, like a family meeting, or informal, could be once or multiple times, could be with just the patient or the patient and their entire entourage. There are certainly many different contexts when engaging with patients and their families, resulting in many different ways to engage. But I want to share some key engagement pearls. First is adopting curiosity, or what I like to adopt specifically is exquisite, compassionate curiosity. And when I run family meetings, I generally say very little, and I spend most of the time asking questions, trying to appreciate who is the person in front of me, probing, not taking things for face value. I'll ask questions like, what do you mean? Or state, tell me more, particularly if they're saying something that is different or curious. Recently, we just had a family meeting where a patient said, my goal is to continue to live. And I asked, well, what do you mean to live? Or the resident asked, what do you mean to live? It's also exploring the patient's experience of the illness and the patient as a person parts to allow us to formulate goals of care and make a recommendation ultimately. It means sometimes to hold our agenda on the side to open our minds a little bit more of what's on their minds. And whenever I start a crucial conversation, I like to understand their perception. What is their understanding? Now, often we do ask that question, what is your understanding of what's going on? But I've witnessed where these questions can sometimes go in tangents where we don't really want it to go. My advice is usually provide a context to the question. For example, what is your understanding of what's happened in the last 48 hours? Or what is your understanding of what's happened since your admission to hospital? Or what is your understanding of what's happening with the state of the heart failure? The more you provide the context, the more specific you get an answer and help you direct the conversation forward. And when engaging in these crucial conversations, it's important to invite not only the patient, but their family members into this conversation. The invitation allows them to be mentally prepared. And during the conversation, if we're going into other more crucial topics, it's important to invite them yet again. For example, I've had a patient once ask me, how long do I have left to live after we've explored the disease state and the prognosis? Or not yet exploring the prognosis, sorry, they were asking, how long do I have left to live? And thus asking about prognosis. Before answering the question, I threw it back at them and asked them, are you sure you want to know? And does everybody in this room want to hear the answer? And you'd be surprised in many occasions, one person may stand up and say, actually, I'm not ready to hear this. And even the patient at times will reflect and say, actually, I'm not quite ready, or I need someone else with me. I need my spouse with me to hear that answer. So we hold it off and answer it when the parties who are ready to hear it can be part of that conversation, and those who don't want to be part of it step out. And when we do deliver information, it's important to do it directly, with honesty, and simplicity. Simple language. Now, we obviously know, and we've been taught many times, do not use medical jargon. Yes, but it's much more than that. In fact, it's actually much less than that, as in no complicated explanations. When I speak with patients about their disease states, I really just simply state it in the most simplistic manner. Your heart doesn't work. The pump is not working anymore. The kidneys are not working anymore. They are unable to filter the blood anymore. That's it. I don't go into creatinine. I don't go into the echocardiogram findings in full details. It's too much information most of the time that they can't really fully appreciate. In fact, when looking at communication tools and theories out there, according to the McGill theory, only 7% of what is communicated is actually retained. 38% is the intonation, and 55% is your body language. So what you say is actually very little retained. So the less you say, the more will be retained. And by saying less, I'm giving them the opportunity to ask the questions that are relevant to them. They'll tell me what they really want to know to help them make decisions for themselves. And when they ask me certain questions, it actually piques my curiosity as to why are you asking this specific question? It gives me an idea of who they are as a person and what they value in their life. But after sharing crucial information, the most powerful tool in communication is silence. Silence is awkward, though. It's uncomfortable, but it's incredibly therapeutic. I've actually trained myself to count to 10 Mississippi in my head, and if the patient or family member hasn't broken the silence of a comment or question after I shared crucial information, I'll often ask what's on their mind to direct the conversation forward. But what is the most challenging part when engaging with patients and their families? The emotional response. But to have an emotional response is to be human. Remember, you're not the one causing them to be sad or to be angry. Emotions or feelings are simply reflections of needs met or unmet. Take certainty, for example. Certainty is a need that we all have. Our brain likes to know what's going to happen, what is expected, how our day is going to look like to some extent. Imagine getting a phone call from a loved one who says, hey, I've just been in an accident, and then click, disconnection. What's going through your mind? You'll be wondering what's happening with them. You may be worried, anxious, sad, angry, because you're in the middle of clinic and can't get out of clinic. All these emotions will start to surface. And that is normal because your need for certainty is unmet in that moment. And certainty is just one of many human needs. There are many, many more. There's a concept of the universality of human needs that was developed by Dr. Marshall Rosenberg. We all have these needs. Some are more important to us. Their priority may change with the emergence of life events, like the birth of a child or the diagnosis of a life-threatening illness. The point is, it is a shared reality of being human. Putting yourself into another person's shoes to sense those feelings and understand the unfulfilled needs behind the feelings, that's empathy. Empathy is being open to what is alive in others. It's about walking that journey with them rather than watching them from afar, which is sympathy. Having the capacity to respond to the emotions leads to trust, which is important as you prepare to make your expert recommendation. They know they can be vulnerable with you when they can trust you. So engagement in all of its forms will allow you to formulate the goals of care and make a recommendation. By knowing as much as we can about the illness, how it's impacting the patient, and who they are as a person, we can better navigate between the goals of survival, function, and comfort. So a narrative of a goals of care and recommendation can look like this. After reviewing Mr. Smith's past medical history, we note that he has advanced progressive dementia with an acute illness that caused a decline in cognitive and physical function. In speaking with Mr. Smith's family, it is evident that Mr. Smith never liked hospitals or seeking medical care. We are unsure how much he was aware of his cognitive impairment, but when it progressed to more advanced stages, he seemed content and mellow most of the time without behavioral outbursts. He did start to decline in function, walking and eating less, and needing more assistance with self-care. It has been challenging for the family to watch him decline, but they still enjoyed his presence. They always avoided him experiencing any suffering despite losing certain capacities. Mr. Smith is otherwise someone who really enjoyed life, a joker, as his family would say. He never was too concerned about things in life. He always wanted what was best for his family and cared deeply for them. He never was burdened with fears and anxiety, including no fear of dying. Based on the advanced nature of dementia without a clear prognosis, its impact on Mr. Smith, his family, and his values, the recommended goals of care are to continue to optimize comfort first and foremost. Survival and function can be attended to, but not at the cost of further loss of comfort in the near future. Therefore, interventions such as providing food if he expresses hunger and can swallow, Foley catheter to ensure ongoing urinary functional flow, or providing an oral antibiotic for a UTI are all acceptable. And should his condition worsen, we provide medications to optimize comfort and relieve any signs of distress with the understanding that he wouldn't live much longer. And I would ask the family and the patient, what do you think? Always do a check-in. You see, much of the recommendations are not simply based on a series of medical facts, but rather the patient's values. Oh, here we go. The recommendations are based on the patient's values, their experience of the illness, and their own words. It's moving away from these intervention-based conversation and moving towards outcome-based conversations that will dictate the interventions that best align with the desired outcomes, as in the goals of care. The goals of care can actually dictate the code status, not the other way around. If the healthcare team and the patient with their family can align on the achievable goals, that is getting a better idea of the established priorities between survival, function, and comfort, all the granular questions become significantly easier to answer. Now, let's be clear here. This method is not a guaranteed bullseye method. There are many, many ways of having goals of care conversations and ultimately make recommendations. There are wonderful communication tools out there. And I can't say this method is superior to another. It doesn't follow a strict protocol, but rather is based on principles. But in palliative medicine, our communication skills are like the stethoscope we carry at the bedside. I've studied this tool many times, put it through trial and error, and continue to practice it for several years. It may not be perfect, but has allowed me to listen more deeply and uncover what cannot be seen. I often get asked the question, does this take a lot of time? And the answer is no, but yes. Let me explain. In a talk I attended recently, they said it takes as little as 40 seconds for patients to experience compassion from their healthcare provider. Only 40 seconds to build that connection. And consider this. We wouldn't want to rush an endoscopy or hurry up a thoracentesis. To do these right, you have to give it the time it needs to avoid any complications or adverse effects. So the question isn't, do we have enough time or how long does it take, but rather, do we value the time? To engage in crucial conversations with patients and their families, we need to recognize the value of that time from several perspectives. It provides a foundation to ease future clinical decision-making and streamline patient care, hence answering all those granular questions. It is an opportunity to have a significant impact on the patient and their families to better shape this complex journey we call healthcare and mitigate putting them through potentially unwanted interventions. And finally, it increases your reputation and credibility as an expert, not only from the patient and family perspective, but from all our colleagues in healthcare. And this doesn't apply, these principles don't apply to just physicians. All healthcare professionals have a duty to uncover the patient's values and contribute to the formulation of the goals of care, weighing survival, function, and comfort. So every time I'm about to enter a patient's room and engage in a crucial conversation, I always enter with either a recommendation already in mind, if I have gotten to know the patient and their family over time, or with key questions that I need answered to help me decide which is the best recommendation for their care. Because to make an expert recommendation, you need to engage in crucial conversations with patients and their families, no matter how much time it takes. The formulation of goals of care weighs the priorities between survival, function, and comfort, taking into consideration the patient's experience of the illness in of itself, and who they are as a person. And when it comes to deliver that recommendation and engage, it needs to be done with empathy to build connection and ultimately to build trust. I hope I have given you more confidence in making an expert recommendation to patients and their families when engaging in crucial conversations. something you'll carry in your own journey ahead as you engage in many crucial conversations with your patients and their families. Thank you.
Thank you very much, Dr. Mitri. A virtual round of applause from your co-hosts and from the audience. Wonderful, masterful overview with a lot of wisdom that really focuses on a holistic perspective of patients as human beings, as whole people, and helps to give us a little pep talk as we prepare for our clinical days and engage with each individual who we have the pleasure of participating in their care. So thank you so much. We do have a few questions already in the Q&A, and I welcome folks to bring forward any other questions. There is also the option to raise your hand and to unmute. And then when we see that your hand is raised, we can invite you to unmute your microphone. So I will read out the first question, and then I'll hand things over to Dr. Chung to do the next two questions. And Dr. Mitri, you can just kind of catch your breath, and the group here can take in a bit more of your perspective in response to these questions. So the first one from Mary Jackson: internists and specialists often need to have these conversations in semi-urgent situations. What is the responsibility of specialists and primary care to establish goals of care in non-urgent situations? So in a proactive way, how do we encourage this to happen more often? So speaking with reference to goals of care planning.
I mean, it's important to take into consideration the context, right? It's you know, if you have an otherwise healthy person who's coming in early disease states, you know, where we're not really seeing anything that's threatening, they're not really particularly bothered by their disease, you know, starting to have a conversation about, you know, what are your goals of care and what matters to you sometimes can be off-putting if the context is not right. I think if the patient is giving any sort of clue that they're trying to understand their disease or having a hard time managing it, there's been a change in their clinical status, these are all opportunities to actually engage in this conversation and start to think about what are some recommendations to make. The recommendations are particularly important when I say when we encounter crossroads, right? When you yourself as a practitioner, you're wondering, do we continue this inhaler? Do I continue prescribing this medication? You know, should I send them to another consultant? Once you're sort of hesitating about what is the next step and you're looking, your instinct is I'm going to ask the patient to see what they want, rather than asking them and see what they want. That is an intervention-based conversation. Focus it more on an outcome-based conversation to allow you to direct the conversation forward. So there is an opportunity to do that proactively, but I'd say just be mindful about the context that you're doing it in.
Great, thanks, Mino. Next question comes from Graham Jones, and I think this is something that we've all faced, but how does your approach change in patients or family members, for that matter, with pathologic anxiety?
Pathological anxiety, okay. So I'm going to assume that when we say pathological anxiety, that they actually have a diagnosed, potentially, anxiety disorder, right? So it's important to approach this as, you know, as you would approach with any issues of mental health, right? So this is taking into a moment of validating what the family is going through and the difficulties and challenges, and that they may need to seek also medical care or an attention to make sure that they're managing their anxiety properly. This is not our responsibility. Our first and primary responsibility is the patient themselves. So I think it's about being tactful in validating them, but always trying to focus the attention on the patient and what matters to the patient. And we know this is important for you, or this has impact on you, but let's focus on how this is affecting, you know, Mr. Smith, for example. So it's just redirecting a little bit and inviting them to you know, on the side to say, hey, maybe you should get some, you know, seek some medical attention, because this is going to be really hard. This is a journey. So you're going to need some help to go through this journey as well.
That's great. Thanks, Mino. Next question comes from Dr. Rick Kernu, and it's an interesting one, but and again, something that we often face is how do you handle situations where multiple physicians give different opinions, and also when family members disagree.
I love those situations. So I'm one of those weird ones that like complexity and challenges, right? For now, anyways, we'll see when I get older. What I like about these situations, the reason why I say I like this is because oftentimes we haven't uncovered the common point. Too often, it starts with where's our common ground, and people are already down here at the different branches of the tree. So what I try to do in those situations is let's take a few step backs, maybe quite a number of step backs, to try to find where's our common ground. Where are we starting from, right? Is everybody agreeing that we want what's best as possible for this patient? Great, we can all agree on that. Nobody wants to harm this patient, right? Or this individual. And then we work out of this platform. When physicians or the healthcare team, so I would, because it's not just physicians, I would say sometimes there's discordance, there's disagreements amongst different members of the healthcare team. If the healthcare team is having trouble appreciating where to go next, or are not on the same page, then I think it's really important for the healthcare team to have a discussion apart from the family and the patient to first get their shared understanding of what is going on. Where are we not aligned? What is it that we all understand? Where's our common ground? And if we identify missing points, right? We may identify, well, I don't know what this is. I mentioned the patient's experience of the illness of itself. And who they are as a person as important elements to take into consideration to get those goals of care recommendation. So are there unanswered questions in those categories that we as a healthcare team are not appreciating to allow us to better make a recommendation? So then, delegate a healthcare team member to go and ask those questions, get those answers, document those answers, bring it back to the healthcare team and say, okay, we found out that to so-and-so, this is what matters most, that really what they're looking for the outcome is to function as best as possible. And I've had multiple of these conversations. I remember with surgery, the surgical team at some point, they weren't too sure what to do with the patient. They were doing all sorts of interventions. And when I stated to them, this patient is really not concerned about living as long as possible anymore. All they want is to be able to get home and be there for 2 weeks, finish some of their paperwork, and then go to an end-of-life care placement so they can die comfortably. And once the surgical team understood that and appreciated, they actually changed their interventions and recommendations because they knew how to frame it. They knew, okay, we don't have to worry about this TPN and we don't have to worry about this. All we need to do is just the key interventions to get them home for 2 weeks and then get them to an end-of-life care placement. Once the healthcare team is aligned and in the same page, then it's an opportunity to then go back to the bedside and with the family to then make our recommendation and making sure that all family members are on the same page as well.
Thank you so much. We have a few more questions in the Q&A, but we also have one participant with their hand up for a question. So I'm going to invite Dr. Ann Holbrook to share her question.
Yeah, thank you. Great talk, Mino. I really liked your narrative approach and going back to the sort of older teaching, which was make recommendations as well. So quality of life is a really well-established phenomenon, a ton of research done in Canada, millions of people around the world. Really interesting that, just as you say, it focuses on function mostly, with some on comfort and symptom orientation. Related to the questions that you've just heard, having done these conversations for decades, what I still find really challenging is the situation where I'm pretty sure family is not representing what the patient actually wants. And because of language difficulties or cognitive difficulties, it's difficult. Where there aren't those, I'll try and talk to the patient alone, of course, but otherwise you can't. But just how things come out kind of incidentally, you're quite sure the patient would choose more conservative measures around goals of care. How do you disentangle that?
Yeah, that's an excellent point, and certainly very challenging. The important thing here is, can the patient express themselves or not? If the patient is not in a capacity to express themselves, it becomes even more challenging because you really are relying on the family to truly represent the patient in what they really, really want. When the patient can also express themselves, again, so we're looking at a situation where there is potential conflict in relationships and goals. We have to remember that I'd say, 99% of the time plus, right? Families are coming from a place of care. They love their loved one, right? They don't want to see them go. And I will actually bring that up. And sometimes they'll ask me a question like, why do you do this? And why do you do that? And I just interrupt the questions and I say, listen, I know you're afraid. You're afraid to lose your loved one. And oftentimes just taking a stab at what might be the emotion that is driving their questions and the unmet need on their part, they're going to lose a loved one potentially, and they're going to lose their companion. They're going to lose their sense of security or safety. Just taking a stab at what might be that unmet need. It's incredible how some will be like, oh my God, it's like, you nailed it. You see me, you see what's going on, right? It's just trying to really dig as to what are they really afraid of. So in these moments, when I find that the families are particularly say challenging or very expressive in terms of what they would want, I actually take the patient out of the picture for a moment and really start to focus on them. And I'll have to do that if they are an important factor in peace. What makes it really challenging, especially, is if the patient also says whatever they say, right? Though deep down inside, they don't want it. But what do they want to keep? What's the other need that they have is that relationship, and to make sure that their partner, that their child is going to be okay. They're going to be fine. And if them being alive, they're going to sacrifice themselves for the sake of the relationship to be maintained. So if you're able to actually uncover that and surface that and bring it into the conversation, it's incredibly enlightening. And it takes a bit of time. Those are little steps that you have to take to do that. But eventually the elephant in the room is talked about and things can move along. And sometimes patients and families just have to go through the motions a little bit to see what is going on. But that is what often I'll do, is just really try to uncover what is that need in the family member that we haven't uncovered yet.
Thank you so much for that. All right, so we've got several other questions. We've got a few more minutes. We may not get to all the questions, but we'll take them as they in order. So from Susan Ritchie, what's your advice for new clinicians who are apprehensive about having these discussions?
It's okay not to do them well. It just gets better over time. Just try. And if you find, I should not have, that didn't go well. I should not have said that. That is valuable. I wasn't born perfectly able to have a conversation with patients, say, tell me about your perspectives about death and dying, right? I was not born that way, right? I was trained, I tried some questions. I remember one awkward time when a patient was dying and I said, and the family member said, how are you? And I'm like, well, duh, they're not doing well. Like, what kind of stupid question is that? It's normal in those moments to feel like, oh, that didn't go so well. But we learn. Those are great opportunities to learn. But you'll never learn and get better if you don't try. So just try.
Good one. All right. 2 questions here from Greg Kernew. I'll just read them both at the same time, if you don't mind. How best to handle when patients want procedures, therapies that are unlikely to benefit the patient? And then as well, are there good tools, YouTube videos or websites where patients can learn about their goals of care and how to become more proactive in end-of-life decisions?
Okay, I'll answer the first question, which I already forgot. I had in both the first part of the question.
If they would like procedures or therapies that are unlikely.
Right. Yes. So what boils down there is, again, move away from the intervention-based conversation, move toward the outcome. What outcome are they looking for, right? So if you can appreciate what the outcome they're looking for, and if you think the intervention aligns with the outcome they're looking for, then I would say go ahead with the intervention, right? Some patients will have outcomes that are not the outcomes we would want. I've had patients and family members who said they want to survive at all costs. I remember one patient who said, if I'm in a vegetative state, but my wife can hold my hand, life is still worth living. And that's their value system. I'm not going to change their belief system. Not my belief system, but if the intervention aligns with the outcome they're looking for, then I'd say go ahead. If it doesn't, then that's worth a conversation to say you wouldn't want this intervention because it's actually not going to give you what you're looking for. The second part of the question in terms of tools, there is a lot of there are documents out there. If you Google advanced care planning, my voice, that kind of ask key questions to allow patients to start to formulate their goals and wishes for the future and start to formulate their advanced care plans. But I think, to be completely frank and honest, goals of care is an it evolves over time. I actually did this exercise with the learners. If I were to ask any of you right now, what are your goals in your care if you were sick right now and you knew you had many years to live, you would have all sorts of answers. If I told you you have 1 week left to live, your answers will entirely change. So the context is really important, and it isn't just a one-time document that it's said and done. It's important to revisit those conversations and check in as disease states change and progress.
Excellent. Thank you. I'm gonna, we have only 2 minutes, so this is probably a big topic, but I know this was highlighted by another colleague within the past couple of weeks. So I think it warrants drawing some attention and maybe some follow-up conversations. Wondering if you could review the new CPSO guidance about our requirements to offer resuscitation when there's discordance between patients, family, and healthcare workers.
Yeah, so the CPSO policy basically states that we as clinicians can withhold any life-sustaining, prolonging interventions or critical care or CPR if we think that it is deemed futile. For sure, this is very controversial. And the distinction here is withholding and withdrawing, right? So, withholding. So we're allowed to withhold, we can't withdraw any interventions that have already been instituted, and that you need consent. But to withhold, you're allowed to do it. If families and patients obstruct that, so I always make a recommendation based on the data that I have, and I'll go and present that. And if the family and the sort of obstruct that, I try to take a moment to understand why. What are their fears? What are their concerns? What is it that I'm maybe missing out? And if there really are obstructing, the recommendations actually are to consult colleagues as well. So you say, you know what, why don't we get another opinion? Someone can come and talk to you. And we have done that a few times. I have actually done that in other hospitals where I've worked, where we've asked critical care physicians to weigh in and provide a consultation. There's no critical care emergency at this time, but then we want them to weigh in as to what is the best course of action. And ultimately, we do have the ability to say, no, we're not going to do an intervention. I know this sounds very hard as a concept to appreciate, but it's akin to surgeons who will refuse to operate. A patient cannot twist the arm of a surgeon and say, you must operate on me. They are fully allowed to say, no, you're going to die on the operating table. I'm not going to operate, right? And the same applies to critical care physicians. It's not less of an intervention, right? It's not any less critical to go to the ICU and be intubated. And a critical physician say, I'm not going to bring you there because you're going to essentially die there, right? There is no point for me to take you there. So that we can't dismiss our ability and our expertise. The question is your certainty in that, and that's why having other colleagues weigh in and document that is really important.
Excellent, thank you. And I know that's a huge topic. You really provided a great overview in a very short period of time. So thank you very much. And with that, I'll bring our rounds for today to a close. I want a huge thanks to Dr. Mitri for providing this really stimulating discussion for all of us and lots of good food for thought. Thanks also to Dr. Jason Chung for co-hosting with me today. It's really valuable for us to have our heads of service co-hosting the rounds and continuing their important leadership roles. Just quickly, we do have several upcoming rounds. Next week will be chief medical resident rounds. with St. Joe's as the host. And following that, on April 6th, HHS will be hosting rheumatology rounds with Drs. Legault and Pereira. So really looking forward to those. Have a great day and have a great week, everyone. Thank you.
Thank you. Bye.